Members, apology. The last meeting overran a little, so it's actually gone into our meeting slot. But now I call to order the meeting as we have a quorum. There are several items. If there is a need, members, we will go up to 7 p.m. if there is a need. Now, first of all, information papers from the last meeting. I won't repeat them. They've been sent to us after the last meeting. And now items for discussion at the meeting. Perhaps we can invite the administration in. Next meeting will be on the 16th of May. The administration has proposed 2 items. 1. Voluntary accredited register scheme for healthcare personnel who are currently not subject to statutory regulation. 2. Policy on rare diseases and drug for rare diseases in the Samaritan Fund. Members, you wish to consider? Shall we take up these items? Any other comments? No? Then, well, then we will take up these 2 items. But if we couldn't finish today, maybe another item will be deferred to the next meeting. If there's nothing else, let's move on to item 3 on the agenda: operation of the public-private interface electronic patient record sharing pilot project and the electronic health record sharing scheme. So I hope we can cover the paper. The first one, there's new paper tabled, a response from the government to submission. Now, can I invite the administration to take us through the paper quickly, and then we'll see if members have questions. Thank you. Thank you, Mr. Chairman. First of all, let me give you the background to the 2 schemes. And then we go to the issues to be considered about the transitional arrangement as asked by some members. Now we go to a private clinic. Now, for consultation, patient records are dealt with differently. Some may still be using paper records, and some clinics may store patients' records in the computer. And for some medical groups or private hospitals, they probably have a computerized system. So within the same group, different computers will have access to the same patient's record. Over a decade ago, the government believed this was not a desirable situation because there are more and more patients who may both get healthcare services from the private sector and the public sector at the same time. So as they seek consultation through these various channels, we hope they will have easy access to their own patient health record. So that's why we started a one-way sharing pilot scheme in 2006. So private practitioners will have access to patient records of the hospital authority in that direction, but HA doctors won't have access to private clinics' patients' records. So that's what is meant by the one-way scheme pilot. And that one-way pilot is meant to test whether technologically it's feasible to have transmission of electronic records this way, and then also whether the process is cumbersome and if users would accept the arrangement. Now, in the first year, of course, there was not overwhelming response, but over a decade, the scheme has proven its worth increasingly. And then by last year, over 400 patients, about 3,000 private practitioners are now using this one-way pilot scheme. As I explained, the purpose of the one-way pilot scheme is that it will pave the way for a two-way system for the benefits of patients. So for when patients go to the public sector, they will have access to their private practitioner's record and vice versa. In 2009, we were granted funds by the Finance Committee. We've been developing a two-way system. And then in the past few years, we've also drafted relevant legislation. The legislation was passed last year. And so in March this year, we officially launched this two-way electronic system. And this system is of great benefit to patients because through the system, whether patients visit the private facilities or public facilities, the doctor seeing the patient will have access to more detailed information about the patient that will help to reduce risk of allergy to certain drugs, or there's no need to repeat tests already done by other parties. So the two-way electronic health record sharing system, EHRSS, will be of great benefit to patients. We started the system in March. And during discussion at this council, some members asked, well, maybe some patients believe they think they are happy with the one-way system. They are not ready to switch to the two-way system yet. Is there any special arrangement? At the time, we explained that we cannot imagine that on day one, all 400,000 patients would switch to the new system. But we won't want to say that starting from this day, you won't be able to use the old system, you have to switch to the new one. So that's why we explained there would be a transition arrangement. That means for patients already in the scheme, as well as for doctors in the scheme, if they choose not to switch, they want to wait and see a bit longer, yes, they can still use the old system. But for new patients joining scheme, they cannot join the one-way scheme anymore. They have to join the new two-way scheme. So that's what we mean by the transitional arrangement, and we believe this is a reasonable arrangement because a pilot scheme is a pilot scheme after all. And we believe at the end the two-way scheme would benefit patients more. So that's why after the new system has been launched, we would like to encourage people to join the new scheme. So that's what the paper seeks to do, to explain to you the transition arrangement and the nature of the two schemes. Thank you. 6 members have indicated wishes to ask Mr. Charles Mok, Mr. Poon Siu Ping, Dr. Hon KWOK Ka-ki, Mr. Yu Si Wing, and Dr. Elizabeth QUAT. 3 minutes each. Mr. Charles Mok. Well, the Bills Committee spent over a year to consider the bill. Eventually, the bill was passed into law, so we're now able to launch the scheme. The scheme has actually started, but I find it strange that the official did not report the latest situation in the implementation to us, say for hospitals or practitioners, how many have joined the scheme, what about end users, how many are in the scheme, and are there any indicators or are there any promotional efforts to be made? Can you explain, please? That's the first point. Second point. Now, we have recently witnessed incidents in relation to the hospital authority systems. On Sunday, I went to see them, and the hospital authority colleagues spent time to explain the problems to me. But anyway, that's not within the scope of today's discussion. But it seems that the hospital authority may have to embark on a series of reform measures in future. So can I ask you this? For this current patient record system, in terms of the system itself and in terms of the manpower shortage for the IT team in HA, would there be any impact on this scheme as a result of those two factors? I'll ask Dr. Chiang to answer the second question of Mr. Mok. First, on the progress of implementation. We launched the scheme in mid-March. Actually, the response is a lot better than we have expected. As at last Friday, 55,000 patients have joined the scheme, the HRSS scheme, that is, compared to the old scheme. It was only till year 4 that we reached the figure of 55,000 for the old scheme, but for the new scheme it's only week 4, and we've already reached a number of 55,000, so that's encouraging. As for the participation of private hospitals and clinics, all 11 private hospitals have joined the scheme. For private clinics and medical organizations or health organizations, over 300 have submitted applications. And of course, we need to do some document check, and we would also make an appointment to go and visit their clinics and install some software. Now, so far we have processed 120 applications. So what's the comparison with the old scheme again? Mr. Chairman, can I finish? Yes, compared to the old scheme, well then, actually it's comparison, it's not a like-to-like comparison, because for the old scheme, we use individuals as the units. In the old scheme, there are about 5,500 doctors and nurses in the scheme. And here now, in this scheme, I said we have dealt with the applications of 120 organizations. And we're talking about 1,000 doctors and nurses in these organizations using the new system. This is only the first month because we are now, today is the 18th of April. And that means there are close to 1/3 of doctors and nurses in the scheme compared to the old scheme. So again, the response is better than expected.
The recent CMS incidents, what bearing that has on the EHR sharing system. So first of all, I'd like to highlight that actually they're two totally separate installations. So I think, Charles, you understand that. The EHR is housed in separate sort of data centers from the CMS. There are some technology similarities, but they're actually totally separate. And so there's actually no way that CMS problems could directly impact on EHR. Yeah. But then the next question is, could similar things happen, for instance? So again, I think the problem is that CMS is a much more complicated environment than EHR. It's a much bigger system, and there's a lot more transactions. So it's, you know, anything that happens will have a bigger impact on CMS. EHR is nowhere near that level of complexity yet. But I think, because as I said, there are similarities in a lot of the technology. Certainly, I think we will continue to look at, as CMS, as we find out the things that we need to improve in CMS, and as we work out better ways to do things, I think we will reflect those back to the EHR to make sure the EHR also learns. But in terms of technical risk, certainly it's lower for EHR because it's simply nowhere near as large.
HA 人手方面呢
Would there be sufficient staff in the
The staff issue? In fact, the IT staff overall in the whole of Hong Kong, as we know, is a bit tight at the moment. At the moment, in terms of EHR, at least in the operations side, it's not a big issue. I mean, I think we're adequately staffed for that. So I think this is something we certainly need to keep an eye on, but it's not an immediate, you know, problem as of today.
Okay. 潘兆平議員，多謝主席。
Mr. Poon Siu Ping, thank you, Mr. Chairman. Well, about the two-way system, we're told just now in 4 weeks, 55,000 people have already joined the scheme. Now, for the old system, there are 400,000 participants. So, of the 55,000, how many came from the old system? And on second question is on the transitional arrangement. I understand you have planned for 2 years, and then after 3 years you review the whole system. Let's say after 2 years there are still people not opting to switch to the new scheme, then what will happen? That means for some in the 400,000, if they choose not to switch, does it mean that after that period the scheme will be cancelled, or would there be another scheme to replace it? Thank you, Mr. Chairman. 2 questions. I just gave you a figure. 55,000 patients have already switched to the new scheme. How many came from the old scheme? How many are new participants? Now, about 45,000 patients migrated from the old scheme to this new one, and about 80,000 or close to 9,000 are new participants in the system. As I explained, 55,000, 45,000, 9,000, or whatever. The figures are much higher than we have expected, because it's only week 5 we reached this figure, and in the old scheme it took us 4 years to get to the same level. So that's about the statistics. Your second question, we mentioned in the paper there will be a transitional arrangement. What will happen after 2 years? You see, we have actually kept the flexibility. That is, after 2 years, and we will do a review. Does it mean that in the 3rd year we'll immediately stop the scheme? Well, we haven't come to any conclusion yet, because it depends then how many are still in the old scheme, and we have to find out why they're still in the old scheme. So it will be in the review in year 3 that will decide whether we'll extend the scheme or not. So we're not going to say for sure now whether the scheme will be stopped after in year 3.
40萬都好。
That means that it can be extended if there are few people who have migrated to it, because you can fully migrate within 2 years. Answer: this is a new scheme, and it is we have obtained quite desirable results. We didn't think that there would be 50,000 already. Now for the patients, they know that the benefits are greater in the new scheme. So we are confident that by year 3, most patients would migrate to the new scheme. Well, if there is quite a number who have not migrated, then we need to have a review to see if we need to extend the transitional period. Mr. Leong Ka-lo. In the Bills Committee, the old scheme, it was said to be maintained for quite a period of time. There was no transitional period mentioned. Now, this transitional period now, it is said that the old patients and old practitioners could still use the old scheme. And by 13th of March this year, the new scheme was stopped, accepting no further new entrants. So this is what would like to be discussed here. We are not arguing about this new scheme, whether it is successful or so beneficial. But the fact is that the old scheme, there are 400,000 patients and 5,000 doctors enrolled. And now here, the new scheme has about 120 institutions, 1,000 practitioners, and about 50,000 patients. Now, in the old one, there could be up to 10,000 practitioners involved, or healthcare personnel involved. I don't mean that the new scheme is not good. However, the new scheme has to catch up, and that could take a long time. For instance, if there is a new patient, not yet registered, and he goes to a doctor, the doctor has not yet registered in the new scheme, and he cannot access his files in the HA. This is a fact. I'm not saying that you are playing around with words, but on the contrary, a new doctor, he had not registered before, and when he wants to register, he has to wait. Now, the 400,000 patients, among them, if they go to this doctor, he cannot access the old scheme, the 400,000 files there. So the transitional arrangement, if you are maintaining it, so you would allow new patients and new doctors to enter. And once your new scheme is up and running and functioning good, you should give them, the patients and the doctors, a choice. And then when it proves to be good, then you can stop the registration on the old scheme. Because people are concerned with the privacy, and in fact you need to give the patient a choice. I have a motion here that's being circulated. It's not seconded, but I would like to have it recorded, and I would like to see views on my motion. So, thank you, Mr. Chairman. I'd like to clarify one point. Whether we are playing around with words, are we going backwards? At the Bills Committee, I think we should really look back on the records. There are 400,000 joining the old scheme, and about 3,000 practitioners using it. Now, do we have arrangement taking into account their interests? We understand that the new scheme is not a mandatory scheme, it's a voluntary scheme. So for some patients or some healthcare personnel, if they don't want to join the new scheme yet, they want to reflect on it, I think this is entirely normal. So for those who are now using the old scheme, the doctors there, they should be able to use the old scheme in this transitional period. And that is what we mean by transitional arrangement. As for the other schemes by the government or in the private sector, when we buy a new car, when a new manufacturer has a new model and stop the old model, the manufacturer would have a maintenance period for the old cars, and they would continue to furnish maintenance for a transitional period. And such is our consideration. That's what we mean by transitional period. Of course, that can be long or short, the transitional period. So provisionally, it's going to be 2 years, and by year 3, we'll have a review. We could extend it, and we could also stop it when we think that it is suitable. So that is why we need to have a transitional period where 2 schemes will run on the same time. And that is what was discussed. And secondly, there were 400,000, and now you have 50,000 now in the new scheme. You compare the old and the new, 3,000 versus 1,000. Now, I think it is a matter of time, because the old scheme was from 2006 to 2016. So in the span of 10 years, you reach such a figure. And it was by year 4 that we reached a figure of 5,000 personnel, healthcare personnel. So I don't agree that the new scheme is not as popular as the old scheme. And the third point, Dr. Leung said that 13th of March, the scheme is going to be stopped. Now, if we give you 7 more days, would that be a announcement? In fact, we have already announced to the PPI EPR in December, and we said to them that if you want to migrate, you should pre-register and you should read the documents in related documents. So a few months back, we have already announced it. Now there could be private sector, the doctors and the health personnel have not read the documents sent to them in December and January. In fact, way before, 3 months ahead, we had already announced it. The chairman, in fact, there could be doctors, they could want to access the old scheme and they cannot see the records. Well, the example mentioned, you can also see the medical society's letter. So it says that here that the application could take a long time. It takes a long time to process. And you have to read a lot of documents before you can hand in your application. And the letter, we only got to read it a few hours before. In fact, we had already given a similar response to a letter addressed to us before. The whole scheme, especially the private facilities, if we have to handle such a lot of number of applications, they cannot be processed all in a short period of time. What we can do now is, as long as they have all the documents, we will try to go to the clinic within 2 weeks and to install the software. If, installing the software is a simple matter, they can also do it by themselves. Now, we are now trying to deploy the manpower to take care of the applications from the private clinics. Secondly, is it very cumbersome, the application? In fact, in early days, there were 2 more forms that were needed to be filled in. However, we have already simplified the forms. There are 2 pages. Once you have filled those in, we can process them already. So we are simplifying the procedure. We feel that at the waiting period would not be detrimental to the doctors and the patients. We feel that the new scheme is more desirable than the old one. And for the old, for those who are in the old scheme, they should be encouraged to migrate to the new one. They should not go back to the old one. Mr. Chen Wei-yip. Mr. Chairman, this is a very important question raised by the BC. I was not there. So my doctor used the old scheme, and my doctor could have access to the files in the HA. So now you have the EHRSS. The old scheme is not functioning, is it? The 100,000 patients, the information about the 400,000 patients are not accessible. Is it accessible? Well, if it is an old patient and he does not want to migrate to the new scheme, there is a transitional period. The old doctor can still go to the old scheme. However, for a new scheme, if the new doctor has not joined the old scheme, he cannot access it. If his doctor is gone, and the new doctor cannot access his old files in the old scheme, it is dangerous for the patient. There could be incidents and misjudgment. Because health records are very important. Answer. Health records, there are different channels where you can obtain them. PPI, the EPR. Please reply simply. In fact, patients can directly go to the HA. But answer me simply. I have my old doctor is gone, and I have to go to consult a new doctor, and this new doctor cannot access the old files in the HA. I'm asking you, the new doctor cannot access it. They cannot go through it by this system, but by another channels. How long would that take? Other alternatives. If they had in the new scheme, they can see it in the new scheme. But you can go to the HA to have a paper file. You have the right. Well, how long would it take? Well, it depends on the length of the health records. So they cannot access the electronic records. Why is it that the new doctor cannot access the electronic records? If he joined the new scheme, he can. If he joined the new scheme, he can all at once see the new electronic records. So what is the time difference? If the patient comes directly to join the new scheme, but if I'm gravely ill, near death, if the new doctor, if the clinic has not joined the new scheme, put it simply, I think that the two members are saying that the new doctor is not in the system. He cannot access the files. We know that time is as precious as life for the doctors. I don't understand why it's so bureaucratic. I was not at that Bills committee. So what about doctors abroad? I'm in Canada, in a doctor's clinic. I have pain in the chest. So how can the Hong Kong doctor obtain the files? I'm saying that this system serves the Hong Kong system. If he is in Canada, of course, the doctors there cannot see the files in Hong Kong. Mr. Chen, I'm not, the chairman, we are not examining the bill. Chinese medical practitioners in the scheme? So you do not have Chinese medicine records. in the scheme. You are discriminating on the Chinese medicine because they can give sick leave. Why can it? There's no files on the Chinese medicine. So this is the last question. Mr. Leung Ka-lo is well versed in this area. We have 4 items on the agenda. There can be a second round, 3 minutes each. I do not want to waste time arguing with you. Please be respectful of the council. I'm not giving him 9 minutes. Mr. Leung Ka-lo has used about 2 minutes. Mr. Yau Si Wing.
因為佢醫生可以9分鐘啊！
主席可以講啦嚇，
主席係唔公道啊嘛！
姚思榮
Mr. Yu Si Wing. My doctor can use 9 minutes, and I cannot use my allotted time. This is privilege. I am protesting. I am opposed to privileges.
發言時間用好嘅。
Mr. Yu Si Wing, is your turn. Mr. Yu Si Wing, is your turn. Mr. Yu Si Wing, it is your turn. I can't speak. He's so loud. I can't hear myself. It's your time to speak. As the chairman, you're abusing your power. As the chairman, you're abusing your power. Shameless. Mr. Albert Chen, maybe I can follow up on your question, okay? But he's discriminating. He's doing what C.Y. Leung does. Let me follow up on that question. Mr. Yu Si Wing. Mr. Chairman, if I may pick up on Mr. Albert Chan's question. Well, you're free to ask any questions. There is now a dual-track system. I think what Dr. KY Leung said makes sense. That is, if the new doctor wants to join the scheme, he can't join the old scheme. So, but then you say you can't speed up your existing support because there are now all of a sudden many people wanting to apply. And then in a transition for doctors and patients, it would be unfair to them because patients won't have access to their have difficulties accessing the record. So for the new doctors, would you speed up the processing? Then Mr. Albert Chen doesn't have to be so angry because the new doctors' applications are being held up, and so is there a way to speed things up, especially for them? Well, let me explain. During transition, new doctors can't join. That means they can't join the old system, but new doctors could join the new scheme. And for the new system, actually, there are more functions available than the old system. That's the second point. Many are wanting to join the new system. That's why we deploy more staff to deal with the new applications. So hopefully then we can process all the applications quickly. Now, would there be more support? Well, yes, we deploy more staff. That's the first thing. Secondly, I have streamlined the workflow. We've already put those measures in place. We've explained to the medical council already what the arrangement is. You say you expedite the things, but the members are saying that you should expedite things so people are not held up in any way. Because those already in the system can still access their records in the old system, but for those who join the new system, they may not get the records yet. So that's why people are worried. But now everybody joins the queue, and they're all treated equally. That means for new doctors, they have to join the queue, and then they have to apply, and then for paper-based records for the time being, instead of electronic records. And I think that's exactly what they're talking about. For the applicant, before he joins the new system, he can still use the old system to access patients' records. That means he will still get access to something. As for the processing of new applications, now what is the problem with that now? There are people who submit forms, as you know, maybe often people omit some information, or there are typing errors and so on. No. But you process the application is one thing, but they make mistakes in the application is another. That's why we have deployed more staff. So we are going to look at the forms as soon as possible, so we can spot early there's any omission of information. But then the second thing is when all the forms are ready, then we have to go to the clinic to install the software. And private doctors have long hours, so we have to find the right time for our colleagues to go and join to install the software. It may not be easy. So what we do is that after we've got all the papers, within 2 weeks we can go and install the software if they've got all the papers. But very often they fail to submit all the required documents. That's why we have to wait for all the documents before we can install the software. Dr. Elizabeth QUAT. From a trial scheme, pilot scheme, to transitioning to the EHRSS, it seems that the public don't quite understand what it's about. That's why Dr. Hon KWOK and other members have raised questions. Now, the pilot scheme is, of course, a transition in itself. And now there's a new two-way system, and you hope that all medical personnel and patients will join the new scheme soon, and then the new system will be phased out. That's what you hope to achieve. But then, right now, there are a lot of doctors who want to register in the new system, or there are clinics too wanting to do so. They find that the processing time is long, so there's a vacuum in the interim. And so there is this gap. So what can you do to make sure there is a smooth transition? Maybe because people are not prepared enough yet. That's why there's this gap. Can you address that? Another point. The question of the safety deposit box. That is, in phase 1, patients may choose who have access to their records. What is the progress on that, please? And when's the second phase? Well, Dr. QUAT asked a number of questions. First, I agree. If there are questions from the healthcare sector, it must be because they don't understand what the transition means. Perhaps the Bureau needs to do more to publicize our work. That we understand is something we need to do. And second point, the waiting period for the applications to be processed is long. But as I explained, after they've submitted all the required documents, we still have to send our staff to their clinic to install the software, or they install the software on their own. And here, there could be several problems. One is they don't submit all the required documents, or two, they have submitted all the documents, but they're too busy. They won't have time for us to go and install the software, or for themselves to install the software. So that's why we are going to have more staff to, so there are more people processing the applications. At the same time, we have more staff to go and install software. Hopefully then we could compress the waiting time. The third point about the deposit box, sort of. Well, we talk about that many times at the Bills Committee meetings. We fully appreciate the concern. So that's why we said once we secure funding for the phase 2 project, then we will work on the deposit box, or we will provide more functions for patients to handle their records. Now we're going to seek funding from LESCO this year for the second phase project, and that will include the deposit box function. Thank you. Dr. KWOK. Well, at the Bills Committee meetings, I heard clearly from the government that the design of the scheme is to make it convenient for existing patients and new participants to use the scheme easily. Well, we've heard what Dr. Hon KWOK suggested. It's easy for the government to address this issue. That is, before the new scheme completely replaces the old scheme, then if there doesn't matter if there are existing participants or if there are new participants, new doctors, participating doctors should be allowed to access the records of patients, and that would have addressed the issue. Now, I have a technical question. I heard it can't be done technically. I have doubts about that. Because it won't add to the technical requirements, because both the new system and the old systems are already in place. You just need to give a code for accessing the website. And there is this device to generate codes, that's all. Why can't it be done? Otherwise, I can see it. You have misled Dr. Leung Ka-lo, and there is really no need for the government to force people to join the new scheme, because over time, if healthcare personnel and patients find the new scheme to be better, they will automatically switch. So why are you trying to force a way through? Is everybody learning from C.Y. Leung? You want to force a way through? Commissioner? Thank you, Mr. Chairman. On the technical difficulties, perhaps I could invite Dr. Cheung to explain again. Now, about the transition arrangement, just now Dr. Leung and Dr. Kwok asked the question. Now, regionally there's a transition, and the government's thinking is that the transition means we must respect patients and doctors already in the old scheme. If they don't want to switch to the new scheme, and then during the transition they could still stay in the old system. We believe that makes sense, and that's why we are now providing this transition arrangement for those in the old system. And we believe the transition should be long enough, at least 2 years, and a review in year 3. Maybe the transition will be even longer after the review. So that's what our thinking about the transition. Some members asked, perhaps during the transition, the old system could still take new applications from doctors and patients. Well, that's the crux of the matter. We don't agree it should work that way, because for the old pilot scheme, if it continues to receive new patients and doctors during the transition, that means this pilot scheme size will grow, and it's not good for people to switch to the new scheme. And the new system actually would benefit patients more than the old scheme. So in terms of the policy intention of the government, we shouldn't be encourage people to use an old system which doesn't offer so many benefits as the new one. So that's why what we want to do with the transition is that for those already in the existing scheme, that they won't be affected, so they stay in the old scheme if they wish. But for people who want to join now, they must join the new scheme. Why can't you link up the new system and the old system? Yes, I can understand your policy intention. For the new old scheme, you won't accept any more new participants, and then 2 years later you do a review. But what happens is, as Dr. Leung said, for those joining the new scheme, they have no access to the records in the old scheme. And so it seems that the old scheme has been frozen in a way. And when patients want to access records of new patients, they can't see them. Why can't the two systems be linked up? And then you could have some sort of an opposite system. If people don't object, then there will be access to both systems. I think that's really the crux of the matter, and it's not against your policy intention at all. You're still not accepting new participants in the old scheme. That's why Dr. Leung asked, how come you can't do it? So it makes it so difficult for the healthcare sector. And you only say now you will speed up the installation of software for the new applicants. But I think that's exactly what he's talking about.
你答一答呢個問題。
Please answer this question.
啊，專員，即係我咁啊，呢啲
The Commissioner, the Chair, this is also a question raised by other members.
你繼續啊。你繼續啊。
剛才都有
The Commissioner, a colleague also mentioned that whatever the merits of the new scheme, you cannot force other people to join the new scheme. So for us, for the patients and the doctors of the private sector, they have to participate voluntarily into the new scheme. And it is also the patient that authorize the access to the records. And for the new doctor, he cannot join the old scheme. But once he's joined the new scheme, and if the patient also joins the new scheme, well, the new doctor can see the records of the new patients, but he cannot see the records of the patient that joined the old scheme. So Albert Chen and other members have raised the same question. So you are pleased with the 50 new entrants, but there are still 400,000 in the old scheme. So do you have any technical arrangement without being detrimental to your policy? So when they go to consult a private doctor, they can still have their records accessible. So, Commissioner.
頭先我問你啊，唔係啊，7分鐘你都繼續問，頭先4分幾鐘你已經唔俾問。
專員，你繼續講翻你個問題。
主席。
Chair, you are speaking to yourself. What sort of chair are you? Well, why can the chair ask so many questions and members cannot ask questions? You are unfair when you preside the meeting. He has to answer my questions first. How can you preside the meeting in such a way? Are you presiding the meeting or are you raising questions yourself? How can you abuse your power like this, Chairman? Albert Chen. The Chair, I think the discussion centers on the problem, the non-sharing. There's no sharing between the old scheme and the new scheme. The Commissioner, we have all along respect the choice of the doctors and the patients. If the new patient refuse to go to the new scheme, so what sort of chair are you? You continue asking questions. The Commissioner, perhaps you should. Well, I think I will give him my time, the Albert Ho. I protest the abuse of power by the chairman. Every member has the right to a second round. Mr. Mr. Albert Chen, are you raising questions on the second round? I think the chair. The problem is the no sharing. There's no sharing between the old scheme and the new scheme. So there is a lot of problems involved in the functioning of the two systems. So there is no second round of questions. So we need to deal with the motion by Mr. Liang Ka-lo. Now, if we see this diagram, there is no sharing between the old scheme and the old scheme. So it is causing a lot of inconvenience. Perhaps you cannot answer this question right away. Commissioner, I have stressed that whether it be the new scheme or the old scheme, both sides, the patients and the doctors, have to agree on the schemes. So if the old patient is not willing to join the new scheme, then I cannot let the doctor see the old scheme files because it's a matter of privacy. But if he cannot see the old file, there could be problems. We should go back to the motion of Dr. Leong Ka-lo. Is there anyone supporting this motion? Mr. KWOK Ka-ki, he second the motion. So if there's no discussion, then we'll vote. Please read out your motion. We urge the government and the HA to restore the PPI-EPR, the original functioning of the PPI-EPR, including accepting new patients and new HCPs into this scheme. Are there any amendments? If not, we'll vote on it. Those who are for, please raise your hands. Those who object, raise your hands. Those who abstain, raise your hands. So there are 4 in support of this motion, no opposition, and 1 abstains. So this motion is adopted. I hope that the Commissioner would go back and see how the old scheme and the new scheme can be connected, linked up together. The second item of the agenda, the injection to the HMRF. You have the documents. If you have any pecuniary interest in any form, you have to declare. So let me invite the officials for this item. We'd like to welcome the administration for this item. So the Under-Secretary for Food and Health, maybe you can briefly introduce the item. It is a matter of passing through. Today, we'd like to hope that you will support us the injection of 1.5 million into the HRMF for it to operate from 2017-18 to 2021-22, and we'd also like to have your views on the consolidation of the scopes of the HMRF and the HCPF. In 2011, the HMRF was established with the 1,000 million. We would also, this is to improve the people's health and to strengthen the system and to have better care, health care and clinical care. So now the amount uncommitted is not enough to take care of the applications for 2017 and 2018. That is why we need a fresh injection of funds so that we can support scientific medical research. And we hope that there could be a synergy to provide more support to research as the promotion of healthcare and simplify the procedure. And so we hope that we will also review the consolidation of the HMRF and the HCPF. In the document itself, the injection of fund will cover the areas that were mentioned in the document itself, that I will not go into the details. Apart from this research fund, we will also support research fellowships to train medical research personnel. Now it is open. The floor is open for questions. There are two. Helena, Ms. Wong. Is it Helena Wong? This research fund is for the HA or the EHP or for the HPA, or are you opening it to the public? Anyone can apply. Can universities apply, or is it to be done by the universities or by the hospitals? And how are you going to use these funds? Thank you. There are several areas that we'd like to cover in the fund. It is an open call, the HMRF. University personnel, healthcare personnel, healthcare providers, they can all apply. It is open to them. These belong to the investigator-initiated research projects. There is a second part of it. This is the commissioned research programs. These are specific programs commissioned. For instance, a research on infectious diseases when there is a breakout. So for these themes, or there could be also themes centering on the health policies, we would commission certain institutions to research on these themes. The third part is the research fellowship. To enhance research capability, they are mostly focused on university grants. UCC and RGC have their own research funds for universities to apply. As for policy research funds, they can also apply. So compared to the RGC funds, how do you gauge the difference between this UGC grants and your HMRF grants? There is a difference in the calculations for the applications. In fact, this HMRF are government funds from the the FHB. So there is RC that will examine the applications of those three sorts of projects and programs and fellowships. We will not look into the fact whether they are also with the RGC, but of course there should not be any overlapping in the research themes. We will also look into their capability of carrying out research. And in the processing, there are different tiers. There are local examination and approval, and also approval from abroad. We are focusing on applied research and not theoretical research. For the RGC, they are mostly theoretical research. And in medical research, our fund is the only one on the medical research, and we are focusing on applied research to improve clinical care.
Dr. KK Kwok, I have two questions. The first one, yes, there is a committee for this fund, but what about the research outcome? How is it evaluated? Some members asked about whether it's applied research and so on, but I don't see much details. I see a few examples in the paper. From 2007 to now, you have funded 37 projects under the seeding fund, and for other projects, the sum involved is substantial. 634 projects, totally spending an amount of $334 million. So how do you assess whether the research outcome is practical? It's not just the universities. There are local researchers as well. Do you have any figures? Are there many of them, say, local research students in universities? How many of them have received support? And what about overseas graduates? Is there a breakdown between local and overseas research students? In other words, is there a policy to favor local researchers? That's my question, really. Thank you. The research fund is really for local researchers. For overseas, so there won't be many from the mainland, not many research students from the mainland. Well, even if they're from the mainland, they may be working in Hong Kong. So here we are talking about local researchers. No, I think you can understand what about our position. There are many local research students who cannot obtain sufficient research funding, so they cannot continue with their researches. And many have told us it's because there are mainland research students studying in Hong Kong. So that's why I asked whether there's any such information or statistics. Perhaps Dr. Ma could tell us if there is such a statistics. Well, we don't have such a breakdown of figures at hand. In considering the applications, we don't actually distinguish between local and mainland researchers. Rather, we look at the merits of the research, the scientific merits. And then there is a peer review, as you know. So they will just look at the originality of the research subject or the importance of the research, whether it involves a major disease in Hong Kong, for instance, and then the methodology, is it feasible and credible? And what about past track records? So these are all considered in deciding whether to grant the application. So if you don't have the information now, can you do some statistics and give us the information later? Well, yes, it will go back and check. My first question. Yes, your first question. Whether we assess the effectiveness and practicality of the projects. Perhaps my research office colleague can explain. Now, for every research project, if we grant a fund, we ask for detailed reports, and the detailed reports will be sent out to experts for review. That is the effectiveness and of the research and so on. And maybe Dr. Ma could explain. Well, yes, after every scientific research project is completed, we ask them to complete a questionnaire, and we adopt the internationally validated approach, that is the Buxton questionnaire. So the researchers have to provide a lot of information in relation to the research, like whether there's new knowledge, identify whether there will be improvement of clinical services, building the capacity of scientific research, and so on. And after the project is done, could it be applied in Hong Kong, and so on. So we ask for all such information for review. Please give us the information about the Buxton-Haney review results. Okay, we can do that. Mr. Halbert Ho, when the Undersecretary answered Dr. Helena Wong's question, I don't quite get it. What is the difference between your fund and the RGC funding? What are the funding criteria? And then in the annex, I see a number of research projects mentioned. They're all related to local clinical experience. And as a result of the research, there have been some changes, or perhaps not changes, but they have an impact on our policy, like about immunization. Now there's a pilot scheme and so on. But internationally, well, there are some standards, I believe, but is there any way we could confirm that the research findings also have value in international arena? For example, are they published in international journals? Is there any international response? Well, I believe that's important too. That should be part of your evaluation criteria. Do you do that? Thank you. For the RGC, well, let me explain again. Funding comes from the Education Bureau, Research Grant Council. And for us, this comes from the Food and Health Bureau and its research office. For the RGC fund, it covers an extensive range of subjects, from art subjects to science subjects. There are many different panels. For us, our focus is on health and medical research, so that's one distinction. And then on vetting, the two panels are completely separate. Perhaps Dr. Ma can explain our vetting procedures, but for RGC they have different panels with different experts. So the two are totally separate. Perhaps Dr. Ma can explain. On vetting, there are two levels of vetting. When we receive application on a research project, we will send the project to overseas experts for initial vetting. If there is there's a such scientific research value in the project, then we will pass the project to local experts for further review. And if the project merits support, then local experts will get together in a meeting, and then they will consider each project. And then they may arrive at the decision to grant or not grant the application. The Research Council will have the final say on the basis of the recommendation of the vetting panel. Now, you asked if some of the research findings are published in journals. Yes, some are. After the project is completed, they must complete a questionnaire. And we require the applicant to inform us whether the research project has been published in any international journals, and then they have to tell us which journal and in which issue. And on that basis, we will evaluate the project. We'll see whether the project has been published in internationally acclaimed journal and so on. If I may ask further about the introduction of these policies as a result of the research findings, are the research findings validated internationally or supported at least by some overseas experts? Yes, there is such an arrangement. Now, after the project is completed, of course, the report has to be submitted, and we send out the report to experts for a review. For instance, if it's published in any journal, that's also evidence that the research project is recognized by the international community because it's published in international journals. Now, RGC supports mostly basic foundation research, but for this fund, the Health and Medical Research Fund, we support mostly applied research in relation to local health and medical issues. Thank you. Mr. Albert Chen. I'm not against research, of course, but at the end of the day, would the public benefit from the research? I think the public needs to be told. Because just reading your paper, we don't know for sure whether the money is well spent. We're talking about another injection of $1 billion. So do Hong Kong people actually benefit from such research? Can you quantify it? Because we're worried that people do research just to gain in credibility, and maybe there's collusion, and the rich and powerful favor certain people. Now we see that the membership on those panels, they are people with influence. So do you have any information for us? Now many medical institutions do research, but maybe someone they do some research overseas. Something's been proven. Why do we have to do our own research again? So just can tell us over the years, based on some of the research projects, Hong Kong people have actually benefited. Can you give the details, please? Thank you, Mr. Chen. As you said, for the research projects, it's about gaining scientific knowledge, and at the same time we attach importance to the clinical aspect and whether the public will actually benefit from the researches. I can give you some examples. For example, that's about the cost effectiveness of pneumococcal vaccination of infants. We have to see if the vaccination is cost effective, and a study has proven the cost effectiveness of the vaccination. So the Center for Health Protection's Scientific Committee on Vaccine Preventable Diseases has recommended, on the basis of the research findings, that heptavalent pneumococcal vaccine be included on the list of recommended vaccines under the childhood immunization program. At the end, how many infants received the vaccination? Well, I don't have the figure at hand, but I think the key question is, we know that there's a certain vaccine that's cost effective. Just give us the information after the meeting. Okay, after the research is done and they make a recommendation, and then how many infants eventually received the vaccination? Well, yes, we could give you the information afterwards. And then on other clinical cases, is similar. Let's say for a particular technology, a procedure, or intervention is proven effective clinically, or it may have positive effect on patients. Then apart from research reports, now I want concrete examples. Let's say over the years you funded so many projects, and how many projects were proven effective, and how many people would actually benefited. I want the figures. Maybe, well, people will get a claim internationally, but the Hong Kong people don't benefit at all from the research findings. Then why should we fund such research? Yes, I could give you the information later. And how can you make sure that in future the research findings will actually benefit Hong Kong people as the primary objective? Now, as to whether patients will benefit or whether there's clinical value, that's actually part of the review criteria.
Is there a mechanism to make that public, to let the public know what you have done? Reply. In fact, all these research reports are on the web and made public on our website. There are also journals that will be distributed to healthcare providers and relevant personnel. Albert Chen, well, there are no figures and no specific cases Well, we are illiterates. We cannot read scientific journals, medical journals. I need specific figures. For instance, how many projects approved, what are the amount spent, and what are the benefits to the public. So right, we will provide you with this information. Ms. Helena Wong. In paragraph 12 on the fellowship, research fellowship, there are members who asked that 2016 you will have 4.85 million commitment to 5 applicants, but we don't have the names of the applicants. And what are the researches that will be done? Are they being done here or abroad? There are no specifics here. And Joa said, so these are for initial or mid-career professionals or researchers. You said that are you giving them to the assistant professors or the students for doctorates, or what are the people that will apply for these fellowships? Would it mean that you don't need to teach anymore? I will let you do the research, or you stop your teaching and you go to the UK and you do exchange and research there. So it's a funding for the local people to go abroad, or for people abroad to come to Hong Kong. It's being given to local professors. Perhaps Dr. Ma can give you more details on the fellowships. I would also like to say that this is entirely new, and we have just vetted the applications, and we have yet to announce them. And we think that in April and May we will announce them. So you are doing staff development for the university then? I think that it is a measure to upgrade the research capability of the universities in Hong Kong. And we also hope that the research projects can be funded, more can be funded. For instance, I am from the Polytechnic, I'm a professor, and what would you fund me for? Mr. Ma, Dr. Ma, there are 2 aspects of it. So there are specific medical research projects where knowledge can be extended. So he can go to local institutions or overseas institutions. There can be attachment there. They can also study there. And the second part is that he himself should also do a research project that is linked to his studies. For instance, he has to do a research in order to be linked to the knowledge that he's going to gain. So he stops his teaching, go there. So once he's finished his research, he has to submit a report to us, and expert group has to examine his research report. And in between, he has to submit midterm reports as well. Mrs. Wong, well, this 1.5 billion, the fund is 1.5 billion. There is the RC and also the another institution. So you are saying that it has to be vetted abroad first, and then come back and vetted locally. For the HCPF, there are not many academics in this HCPFC. How can they judge whether research projects have their merits? The CPFC, HCPF, aims at promoting health projects in the community, for instance. A healthy way of eating, or mental health, or smoking and alcoholism and obesity in childhood, etc. All these projects will allow them to gain knowledge and change their behavior. Of course, there is a certain measure of research, but most importantly, to promote these in the community itself. For the HCPF, we are aiming at local projects and local themes. So they are mostly, the projects are mostly vetted by local researchers. So they are not vetted by the list annexed to us. Well, you mentioned mental health. And in the HCPF-C, do you have mental health experts in this committee? I don't understand why you have a counselor or a head of a school. How can they be qualified to examine the merits of the research? Because the other one is for scientific research. This one is for promotion of health. So in the Annex 1A, it is for scientific research, and in Annex C, it is for the promotion of health. So the committee members are different. That is correct. In Annex C, so there will be projects being carried out. So there are also projects who had something to do with the scientific research. However, in the HCPF, we feel that we need to promote as well the community healthcare, as well as a bit of scientific research. That is why we are thinking of consolidating the HMRF and the HCPF. We are going to review their scopes and to see if they can be brought together. I hope that before coming to the FC, the members of the committees, there are names only without saying who they are. And well, Mr. Chen, Dr. Chen Weiman, Mrs. Maple Chow Mankey, what are their backgrounds? What are their backgrounds that would allow them to sit on this committee? There are no backgrounds to these people. Mr. Chair, I don't think that there's a lot of opposition, but there are certain uncertainties in this document that are not very clear. So in fact, the funds are in two parts. So you have to clearly state the difference between the two, so before you come to the FC. Mr. Chen Kim-po. Paragraph 9 on the HMRF, investigate the initiated research projects. You have over 2,000 applications with 300 approved. Are there any appeal possible for those who failed in their applications? So from 2011, are there very successful projects? Maybe you can give us some examples. That was being asked already. So, Undersecretary, if they fail in one application, they can apply again. We also have given them comments from experts for the failed cases. Are there successful applications and researches that you can share with us? In Annex B, we have given you some examples. For instance, some outstanding success, for instance, the cost effectiveness of the pneumococcal vaccination, or the H5N1 influenza vaccinations for the avians. And also there is also a research on the colorectal cancer in Hong Kong. These are very helpful for our health policies, and these directly benefit the local people. So I think that these are worthwhile efforts, because you cannot do it all by yourself. So you encourage other people to do it, and with good results. And I think you are continuing this good work. Thank you. There is no opposition for this item, so this will be handed over to the FC. Maybe there are figures that you can supply when you come to the FC. So the fifth item, consultation report on regulation of private healthcare facilities. We'll invite in the administrative representatives. Under Secretary, let me briefly introduce the item. If you remember well, in 2014, we had a public consultation. Perhaps I should go back to 2012. We have a steering committee for the review of the regulation of private healthcare facilities. We have done a comprehensive review. In 2014, we had a 3-month public consultation with a report, which presented the scope of the regulation. We feel that we suggest that we should have 3 categories of this PHF, with 19 aspects: corporate governance, standard of facilities, clinical quality, price transparency, etc. Sanctions. We all in 2014, in December 15, and in 2015, January and 13, in the panel itself, we had already given you a brief introduction and a discussion. And in 2016, in February 17th, we had some deputations coming here. In 2015, there have been public consultations. There are about 238 submissions from individuals and organizations, and there's a solid support for strengthened regulation of PHF. There are also many specific submissions, and also suggestions for the scopes of the regulation. We have received general support from the public, and we have also put forward a series of recommendations on the basis of these consultations. We recommended some revamping, simplifying the regulation of 2 kinds of non-hospital facilities. We have changed the names to simplified names for day procedure centers and simplify the other name to the clinics under the management of incorporated bodies. And we also would like to look into the feasibility of have an independent committee on complaints against private healthcare facilities. So these will, when there are complaints unresolved at service delivery level by private hospitals as day centers and clinics and incorporated bodies, it's going to be handed to the independent commission. As for the provision of quotation, we are changing it to provision of budget estimate. So in the policy itself, we would like to, in fact, originally like to see the budget estimate so that we would have a plausible reference of the overall charge for the patients. And in the legislation, we will carefully looked at the level of sanctions and the scope of sanctions. For instance, for those serious offenses, operating without a license or obstructing or not complying with conduct, the code of practice, in order to have this, we are hammering out details of the regulation of the private healthcare facilities, and we hope that in 2016 and 2017, the relevant legislation will be presented to the Council for vetting. Mr. KWOK Ka-ki, I would like to raise a few questions. I think that we all remember, well, there are incidents leading to the reform of the PHF. There are very sad incidents. I am not opposing this regulation of this PHF. However, you have not mentioned the beauty centers. I know that if FHB cannot have a framework for those beauty centers. However, you have to go to the other bureaus in order to work together. As I'm not saying that the clinics and hospitals are not important. However, for 10 years and 20 years, beauty centers are still operating in under satisfactory manner, and we need to have a committee to regulate private hospitals. However, apart from complaints against the private hospitals, but there are also hospitals. There are also complaints against the hospital authority. In each and every hospital under the HA, they are dealing with their own complaints. However, the HA is now losing the public trust. So perhaps the administration now they have a framework of sanctions, and we hope that this committee will have the manpower and the resources to undertake investigation, arbitration, and deal with these complaints. The medical commission is dealing with complaints in a judicial manner. So the mistrust or the misunderstanding of these institutions are increasing day to day. So we are always saying that Hong Kong is an arbitration center. However, I think that for medical disputes, we should use arbitration. If you continue such way of handling things as it stands now, grievances will be increasing. we should first of all go to arbitration before going to the courts. I think the clinics are less a problem, but the hospitals are more important. Sanctions should include imprisonment. Very often, the investors behind those institutions do not need to be liable. If you only sanction the administrators, it is not fair. So is there any way that you can go after the investors, after the investors behind the private hospitals, so that in the policy and in the framework that you can go after them and not only the administrator that only earns a salary?
Thank you, Dr. Kwok, for your questions. Your first question, this started because of incidents like the DR incident. So for high-risk beauty procedures and practices, well, we are very much concerned about it. As you know, there were 4 committees set up, and one committee was set up just to distinguish between medical and non-medical procedures. Of course, our focus is on the high-risk sector. The beauty sector, and like any other sector, operates in a free market, but they're also subject to general legislative control. For most beauty services, they are not invasive. So generally speaking, there is little risk on customers. But at the same time, where there are high-risk beauty procedures involved, we have to pay particular attention to them. We need special staff with special training to handle that. There is not overall control or regulation of the beauty trade, but we just focus on high-risk procedures. It doesn't matter whether it's beauty-related or not. The second question is on the complaint mechanism of the hospital authority. In Cap 113, Section 5M, the hospital authority is empowered to set up a system to deal with complaints from the public or users of hospital authority services. That system is well established. We've actually made reference to the hospital authorities' 2-tier complaint handling system in proposing the new this complaint system for private health sector. Your third question is on sanctions. Yes, we appreciate that. During the consultation, we received views on sanctions. Sanctions must be deterrent enough. And we're talking about serious breaches of the regulations. But at the same time, it's about those involved in the private healthcare facilities being made to shoulder too heavy liability. So we have to listen to your views further and considering the sanctions. Mr. Albert Chen. Chapter 6, which is about fees, as one of the key element of the consultation, and something close to heart to me too. In the private sector, fees cause concerns to the general public. Of course, for the super rich, they may go into hospital just for a short time and they spend $1 million. Well, there are plenty of such examples, and I suppose they mind. But then for the general public, it's easy for the bill to run up to hundreds of thousands of dollars, even for a minor issue. For example, I know a friend, the doctor told him his blood vessels blocked up to 70% and he needs surgery immediately, and that cost $200,000, and asked him to seek second opinion. And I referred him to an old doctor, and actually if, his blockage only 30%, not 70%. At the end, he went to a government hospital, and so it's just 30% blockage. So private doctors try to scare their patients into accepting some procedures. It's not the first case. And then they ask people to pay $200,000. And when you ask for details, so for hospitals, of course, the fees are itemized. How much one piece of cotton wool costs, or so on. All the items are itemized just when you go into hospital. For doctors, especially when it's about surgery, they can charge you $120,000 to $200,000 for just an hour. Now for lawyers, maybe they charge a certain fee and you don't agree, then the judge may make a ruling on taxation. And then eventually fees could be taxed, but then it's not the case with doctors. Even if doctors charge unreasonable fees, there's no way you can argue over it, right? So how do you address this issue, Under Secretary? Would there be some sort of a panel on fees charged by private doctors? Even if you do, so there has to be some sort of an intermediary. A doctor can't charge you $100 for just a 45-minute procedure, for instance, because it is all too common. So how do you address the fee issue? Because when people go into a private hospital, they expect to be robbed. That's what people say. Well, if you are sick, you'll be robbed. You go into hospital, well, it's like you are robbed. How can you address this concern of the general public? Thank you, Mr. Chen, for the question. Yes, we are very much concerned about the question of pricing in hospitals, in private hospitals, because we've received a lot of views on that. And there is much room for improvement where price transparency is concerned. We've done several things. First, under the principle of a free economy, it will be difficult for us to intervene in the pricing level of a private hospital or doctor. But it's hoped that with our recommendations, we could encourage healthcare service providers to be more competitive on the pricing. For example, the budget estimate, provision of a budget estimate that should substantially increase price transparency. And before a consumer receives the service, he knows what the estimate is. That's the first thing. The second thing, for private hospitals, we encourage them to provide package services. No, it's an arbitration system. They may ask for $200,000, $300,000. And it's hard to argue with them. So what do we do? Could there be some sort of arbitration systems like the court? The court can tax the lawyer's fees, and the judge will say according to tax, and then they will ask some taxation experts to do the taxation. So would you have similar mechanism, please? Don't talk about something so vague. Well, we don't have such a mechanism because, as I explained, under the free market economy. But lawyers, it's the same. How come doctors enjoy privilege? Lawyers also practice in the free market. Because what we want, what about surgery? You know, now 1 hour surgery, $200,000, $300,000. Isn't that exorbitant? I think Hong Kong doctors charge the most around the world. So don't you think people are being robbed? You know, in 1 hour surgery, $200,000, $300,000. You can check. You know, the Hong Kong Sanatorium or other private hospitals. There are plenty of such cases. Not everyone could afford it. to afford $200,000 for an hour of surgery? And is it reasonable that $200,000 for an hour, is it reasonable? Now, Mr. Chen, after we've enhanced the transparency of the prices, then consumers will have a choice, but they are robbing people. How can it be reasonable? And we will ask hospitals to publish online the median prices they've charged, so the public will know that if they go for a surgery or a medical procedure, what the range of the price is at both ends. Some private hospitals hire their own doctors. Would you go by the mechanism as suggested by Mr. Albert Chen? Do you mean? But you know, arbitration. I think in C of your paper you mentioned it. If there's going to be an estimate, maybe for private healthcare providers, if they hire their own doctors, you can do that, because then they're no longer just private practitioners as such. So if we enhance the pricing transparency, then we encourage hospitals. Now, if doctors are so professional, why do they worry about arbitration? Even hospitals could give you a list of fees for all items, even for cotton wool, but how-come doctors can't do that? Doctors do list their fees. In that case, why can't there be arbitration if the patients see differently? Because we're not going to intervene with the fees. No, you set up a system similar to the court one. In the court system, at the end of the day, there's a mechanism to deal with fees. We are talking about hundreds of thousands of dollars or even over $1 million in some cases. If you just care about the doctor's interest, of course, you won't consider this possibility. Dr. Helena Wong. Now, this bill won't be presented this year. It will only be tabled next year, right? Yes. For private healthcare facilities, we're talking mostly about Western doctors. What about Chinese doctors? There are also traditional Chinese medicine groups. So you're just talking about Western doctors, and you're not going to work on the traditional Chinese medicine sector? Yes, the current bill doesn't cover, the current law doesn't cover TCM. But for Western doctors, even specialist services are covered, ear, nose, throat. Yes, even dental service is covered. Now, on the complaint system, 18B, paragraph 18B in the paper. Now you will accept complaints. So it's not clear here. Let's say if this complaint is against a doctor, usually people will go to the medical council. And then there could be disciplinary investigation and actions. And here there's also a complaints handling system. So do they come to you first, or do they go to the medical council, and if it doesn't work, then they come to you? Or which way is it? Or do you make a ruling first and then you refer the case to the medical council? Well, for this complaints handling system, for service users, let's say for a particular clinic or hospital, they have a complaint, then the complaints probably can be resolved within the hospital, because the hospital usually has its own complaints handling mechanism. But if the complaint cannot be resolved at that level, then maybe it will come to this complaints handling system. And let's say if there is misconduct on the part of doctors, the medical council will deal with that at that level. Here we're talking about the service level. This complaints handling system is about the service level. I wonder if the Department of Health has anything to add. Dr. Chiu?
Thank you for your question. For this complaints mechanism, we regulate the premises. As for the service, it will involve healthcare providers. If they have problems, they would go to the specialized council. As for the premises itself, we have regulation codes, and that will be dealt with, the complaints will be dealt with. If the complaints committee discovers that it has to do with some specialization, then we will hand it over to the specialization councils. So you are now regulating complaints that has to do with the premises. However, services is quite a large scope. Can complaints be handled vis-à-vis premises and vis-à-vis personnel? For instance, the doctors, the malpractice, or in the surgery, there's a problem with the cotton wool. Can this independent committee handle that? And if it's in the hospital itself, if it cannot be dealt with in the hospital itself, they can come to this independent committee. And if there are some problems related to malpractice in a specialized area, we will refer it to the medical council. So I think that we have discussed the item, and later on you will have some bills about that. So would you add arbitration into your legislation? We do not regulate on the fees. We are focusing on raising transparency in the fees. Well, you're talking about transparency. If the doctor does not comply with the code of practice, there's no sanction or arbitration. We are not talking about regulating the fees. Perhaps this mechanism, there should be a mechanism that is able to measure the fees being asked. So you can perhaps look into the matter where there is a mechanism possible. You have always said that Hong Kong is an arbitration center. Though there are disputes, there should be arbitration, but you are covering up the rich and powerful, and you are really covering up. This is my criticism against you. So the last item of the agenda, we hope that we will finish all the items on the agenda. We can go on till 7. It's still the Under Secretary who is responsible for this item. Thank you. I'll briefly present the promotion of organ donation. Organ donation and transplant ultimately rely on different factors, whether that can save the patient. Not all the deceased can donate their organs, first. And secondly, the HA has a mechanism to coordinate this process. All the clinical parts and also the public's view of organ donation are all being considered. There are several ways we can deal with this organ donation. We have centralized the organ donation register, an electronic register, and there is also the coordinators when there is a brainstem dead patients, when they have made clear that they would like to donate their organs. This coordinator will speak with the family, and subject to their consent, that can be the organs will be donated. Of course, all this information are confidential. Apart from the CODR, the public can also carry donation cards that express their will to donate. So the HD and also other institutions have also distributed these cards to encourage people to take part. The coordinator for organ donation, when they would approach families of these brain-dead patients to explain to the family members and to encourage them to donate the diseased organs. Of course, we know that there are different views on organ donation in the public. So in 2015, in April, there is a focus group to study the ways and means of organ donation and also the reasons for the reservations of the public. And based on that, we are doing our promotion. According to this focus group, if the family members has expressed before death the will to donate, most those consulted would agree, family members can agree to such a donation. So we think that donors should also inform family members of their will to donate. So once the occasion arises, there can be speedy agreement obtained. Now, we are strengthening, we have a promotion committee to promote organ donation in the public. We are also cooperating with the non-governmental organizations to join the centralized organ donation register, and the Department of Health also has a video announcement, public announcements to in 2016 to encourage people to donate. So we are also cooperating with the media to further promote such work. We are also undertaking another investigation because there are different views. We have a survey on the attitude towards organ donation. There could be a mechanism of opt-out mechanism. So we need to have another round of investigation to gauge the understanding of the public on the organ donation, and also we are discussing with the sector. So before any big change is being done, we will conduct consultations beforehand. Mr. Albert Chen, Mrs. Wong.
Mr. Chairman, about families' opposition leading to unsuccessful organ donation. There are 1,941 people on the waiting list. Every year we only get several dozens of donations. So there is a huge difference between those on the waiting list and those donating. How many people pass away because they couldn't wait for a donor? Now, for those on the waiting list who would actually pass away, maybe if the family member would allow to be interviewed and so on, then maybe more people will be motivated to donate. And I think it's important too that the wish of the deceased be respected if he wishes to donate. I think can do more there. Now, of course, if family members oppose, the hospital authority would not force the donation, of course. But that's really against the will of the deceased, because he wanted to donate, but then his family member overruled his decision, and maybe that's a show of disrespect to the deceased. So how are we going to deal with that legally? Could there be some sort of a statutory mechanism? Maybe people can go before a judge, or maybe in front of 3 doctors, the donor gives an affidavit. That is, he will go against all family opposition and he will donate. Can we have something like that? You know, because, you know, in a family there are many different parties involved, the children, the spouse, and others. So could there be a way to deal with it? I hope you'll find a way to do so. We agree we need to do more promotion on organ transplant. As Mr. Abuchan pointed out, as the first step, someone has to first express his wish to donate his organs. And I think the best thing is for them to go and sign at the centralized organ donation register, because this is an electronic platform, and so there will be a record. And the focus group did a study, and it shows that it's important to talk to your family members. While you may wish to do so, but your family members not aware of it, and they may oppose at the end. In that case, the hospital authority won't force it. Perhaps Dr. Cheung of the hospital authority and explain the practice of the hospital authority. Please don't talk about the present. Just consider whether there's a way to overrule families' objection. So I would like to share some experience. In the past 3 years, we've come across brainstem patients that with that brainstem. They did indicate their wish to donate their organs, and they've actually registered with the centralized register. And usually when we talk to family members about their wish, all family members, in all cases, family members would agree. And we haven't yet come across a case of family members objecting in such circumstances. And if family members object, could we have some sort of mechanism so their objection could be overruled? Well, we could explore that. But so far, if someone has registered on the centralized register, 100% family members would agree. How can I read about reports that the family members opposed? These are people who do not know the deceased wish, and there's no proof of that. If the deceased wish is not known, but because he has not registered, and nobody would know what his wish was. You mean he didn't express his wish? Yes, if a person does not express his wish, we wouldn't know. Unless he's on the centralized register, then we know, and then we'll tell the family. Usually the family would respect the deceased wish. And you said you haven't come across a case of a patient willing to donate organ at the end, family members object, and the donation couldn't go through? No, it hasn't happened in the past few years. In the past few years, if the deceased expressed a wish to donate, then the family members would agree. But that seems to be at odds with some media reports, because I've read reports that the family members objected, so the organs could not be donated. That's why we stress the importance of encouraging people to sign up at the register, because then there will be a record and the person's wish would be recorded. Dr. Helena Wong. There are 9 coordinators, organ donation coordinators, covering all the hospitals. What is the biggest difficulty they encounter in the front line? Ms. Tong, please. With brain stem death cases, usually sudden death, and family members find the death hard to accept. So we need to talk to the family members, console them, so they would accept the fact. And when the news has sunken in, then we could talk to them about donation. Now, half of those would agree to the donation. The other half did not, because they were not sure about the wish of the deceased. So they dared not make the decision on behalf of the deceased. So they were not willing to agree to donation, and that would be difficult to deal with because some may think, well, it's good to donate organs, but since they did not know the wish of the deceased, they were concerned. So there's a lot of struggle, there's a lot of hesitation. At the end, they decided no, they won't do it, and that's the biggest difficulty. If family members could find out the wish of the deceased, then, you know, because that's a difficult time we have to bear in mind, and the family is in grief. So if there's a clear record, then it's good. You mean the difficult cases involve people who have registered? No. It's the difficulties with accepting the death. And in many cases, the wish of the deceased not known. And so there's no registration. Yes, no registration or no mention before or without a donation card. So those are the cases with difficulties. So you are now encouraging more people to sign up. So because there will be much pressure on family members as well as on you. So that's not an effective way, right? So now the question is, how can you publicize extensively so more people will sign up? Or maybe family members could sign up together, so family members will know about the decision of the donor, and then things will work more quickly. Of course, this is all about ongoing education. It's about changing people's mindset and beliefs, and you can't do it overnight. So if I could put the question the other way around, could there be any incentives so more people would do it? Have you thought about it? Thank you, Dr. Wong. I think promotion is the first step. As it's mentioned in the discussion just now, expressing the wish is the first step. So for the committee of promotion of organ donation, they would like to work together with the public, and they would like to promote or encourage people to sign up at the register. And of course, it's important that you communicate your wish to your family members so they are aware of it. That's important too. So in the midterm and long term, we need to do a lot more too. As you pointed out, we need to do more publicity and promotion, and we need to let the younger generation knows about the meaning of organ donation. So that's something we have to do. Now, I asked if you could offer any incentive so there would be more people willing to register, or take away some pressure of from family opposition, for instance. From the point of view of organ donation, well, especially in relation to organ transplant, there's a piece of legislation regulating that. If you talk about incentive, it's about how to make it easier for people to register. Now, we've done a survey. If people want to donate, how can we make it easier for them and more convenient for them? Some have suggested whether there are different locations. No, of course, we're not promoting the sales of organs. That would be immoral. We're talking about a person passes away and he's agreed beforehand he would donate his organs. We want to encourage more people to do that. No, I'm just thinking aloud. What about this? Let's say, would it make it quicker for them to get a niche in the columbarium? That means you set aside a zone in columbarium for those who've registered to donate their organs. Or maybe that could be one-stop service of some sort. That is, if family members agree to the organ donation, then maybe you have a one-stop service to follow through. You can think about it, the committee. What about counselors? You need more counselors or coordinators to work on the team so they can be more effective. Now, can we explain better? And can coordinators do more? Well, yes, that's been the direction we're working towards. But as I said, there is a piece of legislation regulating the transplant of human organs and tissues because there is a WHO guideline, and such donation must be voluntary. And of course, commercial dealings in organs are not permitted at all. So we have studied the WHO guidelines, and our approach is to make it easier for more people to express their wish. Now, we've done surveys in the past. Most people actually do not mind donating their organs, but then they may not have the time to, say, go online, make a special effort to go online and sign the register. So in this respect, we like to do more and make it more convenient for people to take the first step. Yes, Garden of Life is that some sort of incentive. Garden of Life in Kowloon's Park. What about Garden of Love Columbarium? So if people register to become donors, or if they pass away, then they could go jump the queue, go to this garden without having to wait. Can you consider it? Well, please go back and consider it. Dr. KWOK, all the new approaches could be considered, including the ones suggested by Dr. Helena Wong. I don't see how they will go against the principles of the government. But I'm disappointed about the figures. The central register, I'm sure Dr. Zheng knows this. The Medical Council has been running the register for some time before handing it over to you, but you can see the figures are really disappointing. Last year, only 20,000 new registrations, 29,300. 2009, 45,000. Now, our population is growing, and the government is doing more publicity. Already it's better than the year before. In 2014, it's just 19,000 registration. So you're only paying lip service to it, and I find it most disappointing. Just now, the organ donation coordinator pointed out the key point. That is whether family members are aware of the wish of the person. I told this to the government many times. You can do it in parallel. That is, you work on the organ donation card and also the registration system. But 2015, only 188,000 on the register. And you can come to LegCo and tell us you've done a lot? Really, do you have no shame? So please don't just pay lip service. You said you need to do more promotion, but can you give us a target? Let's say by the end of this year, we cannot do worse than 2009. How about 50,000 new registrations? And then 2017, 80,000 registration. 2018, 100,000 registrations. So you need to have targets, but you don't have targets now, and there's no policy support and no resources. Very often, when I go to government activities, I never see you handing out the donation cards. Even the hospital authority doesn't give out donation cards in its public activities. If you think this is an important policy, we shouldn't just leave it to the Department of Health, because they do give out the cards. And you should ask other departments to help as well. They should all do it. I'm not talking about the inquiry centers or the Home Affairs Department. Few people go to those centers. In any case, there are many government activities. Why can't you do it? For example, when there's voters registration, you can also provide the cards for people to pick up. There are many opportunities, and you have let go of all these opportunities. So sorry. And then for the donation, it works in particular. It benefits in particular. patients with renal failure. And the figure remains at about 2,000, and it won't go any smaller than that in 10 years, I believe. So you have to deal with that. And then from 2008 to now, you can see there's a drop in the number of donations. So it's not an upward trend, it's a downward trend. And how can we answer to our family? There are not many registering, and there are fewer donations even, and you don't have targets. How can you explain your work?
Thank you, Mr. Kwok. We pay a lot of attention to the figures you mentioned. For instance, the CODR figures. So our policy is that we are now establishing a promotion committee for OD organ donation. At the end of the month, we'll have the first session. We will gather the strengths of the community. So our short-term purpose is to encourage CODR. We also have long-term plans with resources and support. Mr. Kwok said that there are different ways and means to increase the signing up of the CODR. What is the best way of doing it? We are now doing a study. Don't worry about that. It would not be a long study. It is a very speedy survey to understand the wishes of the public. For instance, would there be an opt-out system? People have been asking that. So these are different ways, but we have to know what the public thinks. So after the survey, we will have more information to allow us to go forward. Let me add, opt-out is difficult, and it is not even sure whether it is feasible. As for the purpose, you have not answered at me. So what is your target? For instance, what is your target for this year? Do you have one? Or you don't? For registered numbers, Under Secretary, for the number of registration, there's a lot of room to improve. And we are discussing the target and also the ways to attain the targets. These are all under consultation. The Chair, do you have the resources? Do you need to apply for funds? Under Secretary, for the promotion, we have earmarked resources. How much do you have? Do you have that in the budget? First of all, this committee has just been set up, and we have not yet had the first session. So at this meeting, we will discuss the target and also the ways and means that we have. Because the committee cannot decide on the resources, only the administration can decide on the resources. So don't tell me that you don't know the earmarked amount, because the finance committee will discuss that. So we do not have the figure yet. We hope that we have a detailed plan, and then once we have the detailed plan, we have the accompanying resources. So I hope that there will be huge increases in the numbers registered. So members are concerned about the ways of promotion and also the resources for promotion. Thank you. So the 7th item, other business. So the next meeting is 16th of May at 16 hours. Thank you. The meeting is adjourned.